Good afternoon and welcome to the second day of Caraconference. I will go ahead and give it just a few seconds here as folks filter in, and then we'll get started with today's session, which will be focusing on barriers to care for transgender non-binary people. Couple of housekeeping things you'll already see going in the chat. The session will begin shortly. We will be recording all of these sessions and will be made available after the conference. And if you haven't already, take this chance right now to download our conference program to learn more about the speakers and take some notes in the fillable PDF. And with that said, I will go ahead and get started with our other housekeeping notes today. Welcome again to Caraconference 2021, brought to you by Pickle, Greater Cincinnati's AIDS service organization devoted to positively changing lives in the fight against HIV. I'm Zoe Peach. I use she, her pronouns. I'm a health educator here at Pickle, and I'll be sharing some additional housekeeping reminders before we get started today. If you're not familiar with Pickle, we encourage you to visit our webpage at caraconference.org and to check us out on social media. All of our handles are at We Are Pickle to learn even more about our work. We're probably all well acquainted with Zoom now due to some of the COVID restrictions, but just in case, a few reminders and a emphasis on how we'll be doing things today. Please use the chat function for any technical issues and any general type of questions or comments. For questions specifically for our speakers today, please put those in the Q&A section. I'll be monitoring them along with some of my other colleagues from Pickle, and we'll provide those to the speaker at a natural break in the content. These features are also available if you're joining us from a mobile device in a slightly different part. We do want to give a big thank you to our sponsors for this year's conference. Their generous support allowed us to offer this year's conference free of charge. Our presenting partner is Maytech, the Midwest AIDS Training and Education Center. Our leading sponsor is Gilead. Our sponsor is Theratechnology, Theratech. And our supporters are E19, Lounge Bar and Discotheque, and Johnson & Johnson's Janssen Infectious Diseases and Vaccines Division. We also want to give a special shout out to the Ohio Health Modernization Movement. In the US, more than 32 states, including Ohio, have unjust and outdated HIV laws. The Ohio Health Modernization Movement's mission is to replace these fear-based stigmatizing laws with evidence-based non-discriminatory laws that protect public health. Learn more at ohiomodernizenow.org. On Thursday, we'll have a session focusing on the movement to modernize Ohio's HIV criminalization laws during Thursday evening. So at the end of today's session, please remember to fill out the evaluation that pops up after you exit the webinar. The link is also located in your program and will also be put in the chat. To receive CEUs, you must complete the evaluation before 5 p.m. today to receive credit. And now on to today's session, Barriers to Care for Transgender and Non-Binary People. I am pleased to introduce several of my good friends and also my healthcare providers. So it's really a great honor to be the introducer and the moderator for today's panel, since these are such fantastic folks that we get to work with. First, I'll introduce Ariel Mary Ann, who uses she, her pronouns. She's a local artist and activist in the Cincinnati area. She's an actor, playwright, first-gen college grad, and a dreamer. Her work centers around queerness, transness, and what it means to be Black in America. We also have Kaeden Kass, Master of Social Work and licensed social worker. Kaeden is a licensed social worker at the Cincinnati Children's Hospital Transgender Clinic, where he works alongside a diverse clinical team to support the physical, mental, and emotional health of transgender youth and their families. Prior to his position at CCHMC, a bit of a mouthful, Kaeden spent many years as a sexuality educator and HIV care coordinator at Planned Parenthood and Equitas Health, with a particular focus in queer and trans populations. A transgender man himself, Kaeden is passionate about advancing social justice and health equity among marginalized populations, both on the micro and macro levels. In his spare time, Kaeden enjoys making music, cooking, crafting, and watching terrible reality TV with his partner and their ever-growing pet family. Dr. Sarah Pickle is a board-certified family medicine physician who is fellowship trained in women's health and a transgender medicine specialist. Dr. Pickle is an associate professor in family and community medicine and a physician at UC Health. Dr. Pickle is passionate about training the next generation of physicians in best practices of transgender medicine. With her colleagues, she developed a nationally recognized curriculum on training physicians in transgender medicine. Her recently published research outlines how to train more healthcare providers in transgender medicine in order to care for transgender persons across the lifespan. In her role as a physician at UC Health, Dr. Pickle provides comprehensive whole person care in a family medicine model at UC Health and at the University of Cincinnati Student Health, and she is my primary care physician. So glad to have Dr. Pickle on board today. Last but not least is our moderator today, Dr. Ann Conard. She's the director of the Cincinnati Children's Hospital Medical Center Transgender Clinic. She graduated from Ohio Northern University with a degree in pharmacy and later went on to attain her degree in osteopathic medicine from the Kansas City University of Medicine and Biosciences. Dr. Conard completed her pediatric residency at Nationwide Children's Hospital in Columbus and a fellowship in adolescent medicine at Riley Hospital for Children at Indiana University. In addition, she has a Master of Public Health from UNC at Chapel Hill. Dr. Conard has been treating transgender adolescents since 2005 as an attending physician at Children's Hospital of Pittsburgh. She has held her current position at CCHMC since 2012. Her passion and compassion for those patients and their families led her to establish and direct the CCHMC Transgender Clinic. The clinic, part of the Division of Adolescent Medicine, currently serves over 1,000 patients from all over the Midwest, and I was one of those patients before I graduated out when I turned 24 and came to see Dr. Pickle. So with all of that said, I'll turn things over to Dr. Conard to get us started with today's panel.
Hi, everybody. Thank you for joining us today. Again, I'm Ann Conard. My pronouns are she, her, hers. I think I must have given you old stuff because we've had over 2,200 patients come through now. So the first thing that we're going to talk about today, based on the learning objectives, is we're going to talk about basic medical care for the transgender population. And since Caraconference is mainly an organization for adults, we're going to hopefully focus on young adults, middle-aged adults, and older adults, as opposed to children that I would treat. So Dr. Pickle, would you like to start and talk a little bit about what you do? And then we'll have Kaeden talk a little bit about the mental health side. And then Ariel and Kaeden can both talk to us a little bit about their personal experiences with healthcare and things that they wish were better and things that didn't go so great.
Yeah, that sounds perfect. So one of the things that I put in my bio is providing care within a family medicine model. And I really believe that that is one of the ways that the medical community has a role in optimizing the care of trans-identified persons. In the family medicine model, we are seeing folks from birth to death with everything in between. And one of the focuses of my clinical practice certainly is gender-affirming hormones and other gender-affirming interventions, but preventative and primary care. So one of my goals is to try to help people determine how to live their most authentic lives as they enter different phases of their lives, whether that is a young student who's pursuing their college degrees or their studies, and how might life look different? What does that look like if they're entering parenthood? How might that look if they're caring for loved ones who have other health conditions? What if they are disabled? So, I think in that general medicine model, a small part of what I do is hormone management, and a much, much larger part is that whole person care. And that's really the way that we have a responsibility to envision care for communities that have been minoritized or marginalized, making sure that we understand the impact of hormone therapy on the evolution of other processes in the body. For instance, how might diabetes management look a little bit different? What about cancer screenings? How are we really creating individualized care plans to meet people and where they're at, really taking into consideration other things that are happening in their bodies and their minds. So when folks are coming to see me, usually one of the first priorities on their list is, what about my hormone therapy? Sometimes it's a continuation of hormone therapy. Oftentimes it's the initiation of hormone therapy. As a family medicine provider, but as a physician who really focuses on adult medicine, I might be initiating gender affirming care with a patient who's in their 40s or their 50s or their 60s or their 70s. So really looking at gender affirming care across the lifespan, but really looking at it as one piece of a much bigger personhood that we're considering. I think within the role of adult medicine, we see a lot of the same barriers and facilitators to care. And one of the main facilitators to care is certainly training our adult medicine providers to be able to care for folks across the lifespan. In Cincinnati, because we have such an amazingly robust adolescent medicine program at Children's, there are a lot of young adults who graduate from the program and are ready then for care for the next 80 years of their life. And in adult medicine, we don't have enough adult medicine physicians or other advanced care providers to meet that need yet. And so one of the goals at UC College of Medicine and at medical schools across the country, as well as pharmacy schools and social work schools and nursing schools, is how do we train the future generation of healthcare clinicians to be able to meet the need proactively? And what I mean by that is already having tools in our toolkit. So when a patient comes to us with any gender identity, any medical need, when it comes to gender affirming care, we are not trying to teach ourselves after the patient's needs have already been expressed. We already have the training and the toolkits in place to say, yes, we absolutely can care for you here. And here are networks of colleagues who will also be able to provide you care as your medical needs might change over time. I will leave it there. So much more that we could talk about when it comes to specific interventions, specific things that we take into place. Happy to answer those questions as they come up kind of organically over our time together.
And then Sarah, we should at some point talk a little bit about the actual treatments, because I know that there's a couple of questions for the evaluation, but we can talk, well, I'll make sure we get those in. So Kaeden, do you want to talk about how we treat mental health?
Sure, yeah, kind of like to echo what Dr. Pickle was saying, like I think that when people think about healthcare for trans people, they're thinking like gender affirming care, they're thinking hormones and surgery, and that's certainly part of it. But I have, my role is as a social worker and a provider of mental health services, and also as a trans person myself. So I can kind of speak from both ends of that spectrum. But like my transness kind of intersects with every other part of my healthcare, including mental health. And so I think that that it's really important to integrate like a trans competent lens, into all spheres of healthcare. And so kind of what that looks like for me is I work like within a medical clinic. So like I'm not, I don't work as a therapist or anything like that. And I kind of work to help address and triage mental health issues as they come up in within this primary care and like gender affirming care practice. And so I feel like for folks who have, any mental health issues, which unfortunately is a huge concern for the trans population, I can kind of be like the first line of defense to catch that before, it gets any worse, and to help connect people to the long-term care that they need. So I'll do like brief kind of like psychosocial assessments and brief kind of interviews and interventions with patients and families to try and, if they're presenting with like depressive symptoms, which every one of my patients is basically, I can help connect them to medication management or therapy or school interventions to help address those needs before they become a more serious problem, before they turn into like suicidality and hospitalization and things like that. Yeah, I think I answered the question.
So Kaeden, speaking about suicidality, what % of transgender people do you think have attempted suicide in their lifetime?
Yeah, that's a big one. Like I mentioned that like pretty much all the patients I work with have some sort of depressive symptoms. And the most recent statistics are that about 40% of transgender people have attempted suicide in their life. And that's an attempt, not just thoughts. And so that is a hugely scary number, which speaks to the barriers and discrimination that trans people face throughout all spheres of their life, and speaks to the importance of having a gender affirming framework kind of woven into any any sphere that might interact with a trans person to try and mitigate the weight of some of those issues.
So Ariel, what kind of experiences have you had trying to receive healthcare? What good things have you found and what barriers have you found? What do you wish the providers were doing different or better or weren't doing as well? Maybe.
I guess I can start off with the good things. So in my personal experience, I would say the good things that I've dealt with when it came to finding gender affirming healthcare would be first finding gender affirming resources, if you will. So, when I was a college student, I went to UC and I spent a lot of time in the LGBTQ center. And through the center, I came into contact with individuals like Dr. Pickle, where I realized that, I can't get on hormones. There is a process for me to go through, where I know, okay, this is accessible to me. So, yeah, so I think a big positive for me has just been being able to find gender affirming support. So I think that's the first step in order to make sure that a trans patient and rather trans person feels affirmed. I think another positive for me would be Dr. Pickle herself in the sense that that when it comes to topics of, sex and sexuality, she asks, who's loving on you? Who are you loving on? Which in a way is kind of essentially breaking away from stereotypes and assumptions and things like that. So I think having doctors with an open mind was a very big positive for me. Now, I think when it comes to things that I wish would change, would probably be making sure that healthcare practitioners across the board have some sort of training around gender and gender identity and the basics of pronouns, and why asking people, what are your pronouns? What name do you use? And, and also too, I think a really big one is names on forms, and how some healthcare practitioners don't realize how big of a difference you can have by just having patient's preferred name or patient's chosen name, right? And so, yeah, I think that about covers it.
Yeah, and I think people, just to add to that, like I think people underestimate the importance of little things like that, you know, like having a rainbow flag in your waiting room, or yeah, having a space for a preferred name or pronoun, and then having your like office staff actually look at and use that information. It sounds like a silly small thing, but trans folks have, like, as they kind of move throughout their lives, it's often this sort of like death by 1,000 paper cuts thing, where everywhere you turn, people are, you're getting invalidation and misgendering and blatant discrimination or exclusion. And having just even one adult, like, well, I was speaking from a youth perspective, having at least one person in your life make space for you and acknowledge who you are, but just by using the name that you prefer, can do so much for a trans person's mental health, and also to keep them just retained in care. A lot of times people, you know, if they have a bad experience with, I don't know, their dentist, then that sticks in their mind, and that sucks, and that feels awful. And then they don't go back to the dentist for 5 years, and then all of a sudden they've got like periodontal disease. And so, yeah, these little things can really snowball into much bigger issues for trans folks, either beneficially or detrimentally, if that makes sense.
I think too, speaking off of what Kaeden said about making space for trans folks, I think there needs to be something said in regards to not treating transness as though it is a taboo subject, and just treating transness as just an everyday thing. You know, there are some people who are trans, some people who aren't, and that's it. You know, and I think that by not treating it as a taboo subject, I think that also allows like actual trans people to not feel like they have to mold themselves into a more palatable person for mainstream society.
So Sarah, I'd like to drill down a little bit on the hormones. You know, there's a lot of myths out there, you know, and some of the people in the session today may be caring for people who may be like, but I want hormones. What do I need to do? Can you talk a little bit about the process? Like, does every transgender person get on hormones? And then a little bit about, you know, like the trans feminine hormones and the trans masculine hormones and kind of dosage forms.
Yeah. So, kind of answering the first question, everybody's gender journey is unique to them. And I think one of my roles, and other folks, you know, folks like Kaeden, people's families, people's communities that are supportive of them, is to, you know, kind of think about what are the expectations. So one of the first things that I will do with folks when they come in is just talk about, you know, what do you know about hormones? There's unfortunately a lot of misinformation out there. And the challenge is there's not a lot of wonderfully robust research like there is for cis folks when it comes to medical interventions. And so thankfully we have a burgeoning, you know, blossoming set of research that has been more robust in the years and is ongoing. But a lot of times trans folks are left to their own. They're left to their own to do their own research, to do their own education of their physicians. And so I think there can be a lot of information out there that isn't based necessarily in the best science. And part of then my goal is to kind of align, what might be out there, what might be a misunderstanding, what have they heard that's absolutely true. And each office and practice has a little bit probably of a different approach to the initiation of gender affirming hormones. So in offices and clinics and centers that have a really great multidisciplinary team of mental health clinicians and clinicians who are prescribing hormones, there really is a team-based approach, right? Let's assess what this individual needs. What do they need as far as social support? What do they need to make this gender journey successful? A very small part of it might be hormones. A much bigger part of it might be, what does school look like? What does home look like? What does work look like? What does it mean to come out at work? Are you going to lose your job? And in this country, then are you going to lose your health insurance? And then are you going to be able to see me for ongoing care, right? So all of those things are not things anybody has to figure out before they start hormone therapy, but it is one of the goals of definitely working with community resources, groups and organizations that can support people in understanding, what are my legal protections? What are not my legal protections, in certain states too. And then if folks decide that they want to be on hormone therapy, and everybody's journey is valid, whether they start hormones or not. Some people are very, very affirmed in their gender identity and their gender expression, and there's not a role for hormones, or hormones might have a role for a few years. And then they say, you know what? These medications have really served me well, and I'm in a different spot now, or I've had other interventions and I don't need hormones anymore. So it really isn't a one size fits all approach. And I think that's good. Sometimes I think that's hard for clinicians who are learning about gender affirming hormones to understand, is that we really have to meet patients where they are and check in often, because life is dynamic. Things change, expectations change, bodies change, other health conditions change. So just because somebody starts on hormone therapy at one point in their life and then decides to pause or take a break or develops a medical condition that might not make hormone therapy as safe for them, and they choose with their healthcare providers to stop hormone therapy or to pause, none of that invalidates their experience as a trans-identified person or a transgender person or whatever term they use. So when we're starting on hormone therapy, we can think about kind of two really classes of hormone buckets, if you will. And sometimes we use the term masculinizing to talk about testosterone, or feminizing to talk about estrogen. But, we know that masculinizing and feminizing, those are very cultural terms. The gender is a cultural and societal construct in so many ways. So really, I think about kind of two buckets of hormones to help people reach their most authentic self. So for folks who maybe want physical characteristics and alignment like breasts, softer skin, more curvatures in certain areas of their body, those are people who might start taking estrogen. And the estrogen that we use is a 17 beta estradiol. So it's the estrogen every person has in their body. Every single person. And it's bioidentical, which is like this really fancy term. It doesn't mean anything that's happening like on the off market. It just means it's a hormone that's already in our bodies. So with 17 beta estradiol, these are commercially available. So you can go to your pharmacy with a prescription and you can get these prescriptions. There are times that for various reasons, we might use trusted compounding pharmacies to help make prescriptions that are very similar to our commercially available. You can get them at your retail pharmacy. But typically, these are things that clinicians are prescribing and patients then are going to the pharmacy to pick up and hopefully able to use their insurance or use a discount card. We can talk about insurance at some point as a barrier or a facilitator to care. But so with estrogen, typically we have a transdermal patch. We have a tablet that is an oral tablet, but we will oftentimes recommend it sublingual, allowing it to dissolve under the tongue. And then we have estrogen injections. There are estradiol creams and other topicals as well. The formulations that are available at the local pharmacy are really not meant for gender affirming dosing. So you've got to use a lot too much, multiple tubes a week, which is not cost effective. So if somebody needed an estradiol cream or an ointment, let's say, that might be the one time that we would work with a trusted compounding pharmacy and really make sure that we got down the dosing. When patients are taking estrogen, two things will kind of happen. Estrogen levels will go up and testosterone levels will go down. And we are using our laboratory data, so taking some baseline hormone levels and then watching hormone levels change over time as we adjust doses. And I always say we never treat numbers, we're treating people. So while we use our laboratory estradiol values and testosterone values to guide hormone therapy, and there are some excellent recommendations in the 2017 Endocrine Society guidelines, as well as the University of California, San Francisco has an awesome primary care protocol that really spells out hormone therapy, dosing options, starting doses, lab monitoring. But we are always checking in with the patient. If somebody says, I'm feeling great, these changes are exactly what I want, I'm not going to change dosing if they're happy, as long as that dosing is in that safe range. Sometimes estrogen alone won't lower testosterone enough that people will be happy with other physical changes. So the presence of persistently high testosterone, or things like sexual function that's not aligned with what the patient wants, or hair growth that's really not aligned with what the patient wants and needs, then oftentimes we can add on additional agents to block testosterone, either by lowering the testosterone level itself or through the conversion of testosterone. And those might be medications that people might have heard of, like spironolactone or dutasteride or finasteride. Those are medications. Those are sometimes not for everybody. Not everybody needs those. Sometimes it depends on the age that somebody is initiating hormone therapy, how long they've been on it for, and also if they have the source of testosterone. If they've had surgery and the source of testosterone has been removed, then oftentimes they do not need any additional blocking agents. There are some other agents that might be used in places globally to do some blocking as well. We don't have as much data in the US, and some of those medications aren't even available in the US for us to prescribe. Another one that people may hear about is Cassidex is the brand name, or Baclutamide. It's one that has a lot of internet fervor around it, has not a great safety profile, and would really be used in very, very rare occasions with all the other agents that we have available now. Kind of thinking about that other bucket would be testosterone therapy. And with testosterone, that would be for folks that want to experience a deeper voice or hair growth, or other changes in sexual function, or the stopping of bleeding cycles would be another thing that people would experience. And that comes in an injectable form, a gel form, and a patch form. There are various reasons why folks might decide to do an injection versus a patch. There is also an oral testosterone that is commercially available. Oral testosterone has a lot of liver metabolism, which puts people at risk for other stuff. So we typically don't use oral testosterone, but testosterone can be injected both intramuscular or subcutaneously. We've really, over the last probably 4 to 5 years, as data has supported subcutaneous, we've really moved towards that for injections. It's nicer to the muscle, a little bit easier. Some people still feel really comfortable with intramuscular and they don't want to change, and that's okay too. And similarly with testosterone medication, we're really kind of shooting for various ranges. So we can think about kind of that assigned male physiologic range and use our lab data to guide what might be the upper limits of what we would want to use from a safety perspective. But with that said, for non-binary folks who are using testosterone to really become, they're most aligned in their gender expression or physical appearance, we don't have to aim for high ranges, again, kind of meeting patients where they're at with those medications. In general, the layout of a typical kind of hormone initiation would be, you're going to meet with your clinician, talk a little bit about your overall health. Again, hormones are a small piece of the overall health picture. We will do some baseline labs, kind of make sure that there's nothing else we need to address in alignment with gender affirming hormones. So for a person who has diabetes that maybe isn't under optimal control, we know that if we can help people feel authentic in their bodies, to have control over their health and their outcomes, they're going to be much more likely to also want to care for that body when it comes to diabetes and hypertension. So really using gender affirmation as, a tool for personal motivation to say, I care about this vessel. I want it to be around for a really long time. How can the medical community help me? And oftentimes that is really helping break down some of those barriers that are about access to care or other social determinants of health that are really affecting their ability to access care. So those are the buckets. Happy to go into more details if needed.
So that's great. That's great, Sarah. There's a couple questions, but I think most of them actually are on to our second part, which our second part is talking about disparities, health disparities within the transgender community. So I'd like for Kaeden to start and talk a little bit about that. And then I think we'll answer some of those questions. But just one really quick question. So people don't really use hormones nasally or intravenously, correct?
No, those are two routes that don't have any great evidence behind them, at least at this point, especially intravenously. No reason to do that. Lots of safer ways to get it into the body for sure.
Okay. So Kaeden, if you'd like to start talking about the health disparities, that would be great, that you see or that you think that we have.
Cool. Yeah, there's lots of physical health disparities that we see in the transgender population. Dr. Conard or Dr. Pickle could talk more specifically about that, but for example, trans people are have a lot higher rates of like chronic disease for some of the reasons that Dr. Pickle talked about, right? Insurance coverage, like barriers to employment, which affects insurance coverage, which affects access to healthcare, access to gender affirming care, all those things. And by gender affirming, I don't just mean hormones or whatever. I just mean like a doctor who affirms your identity. All those things, not having access to those things, contributes to higher rates of chronic disease and things like that. From the mental health standpoint, which is my area of expertise, like I already alluded to before, trans folks have like much higher rates of mental illness, particularly like depression, anxiety, things like that. We talked about that 40% suicide rate, which I think is sort of wrapped up in the same thing. Like it's it's just like at a baseline, there are like some things that are like hard about being trans, like not because of the identity itself, but because it can be really hard, to find affirming, supportive spaces, but either at school or at home or at work, and all those things can contribute to depression, and then it's also harder to find care that is supportive and affirming of gender from a mental health standpoint, which also contributes to all that depression and suicidality and stuff. As far as mental health disparities, like that's the biggest thing that comes to mind. There's also a lot higher rates of things like substance use disorders in the trans population. Even things like eating disorders are another big one that we see, which can often be related to dysphoria and are not always, but can be related to dysphoria and lack of access to gender affirming care. Those are some of the big ones.
I think that some of those barriers compounded with issues like race and racism. I think that makes finding access to care even more difficult, because you're already dealing with transphobia, right? From your family, from your community members, right? And then when you tie race into that, you are not only dealing with transphobia, discrimination from family and from community members, but you're also dealing with the systematic racism, racism that has intentionally kept Black people from getting the same access and care to that of white people. And so once you tie race into that whole thing, it makes receiving care a lot more difficult, especially if you are someone who is trans femme and Black, for example, because then you're also dealing with issues of misogyny, harassment, transphobia, transmisogyny, racism from within the trans community, racism from medical practitioners, right? And I think because of all of these issues compounded, a lot of Black trans people look other ways to find access, into hormones, more specifically, looking at like the Black market, because historically Black trans girls like myself, especially in the 90s, they weren't treated the same way as white trans people. And I think that when we talk about trans healthcare and what does equitable access to trans healthcare looks like, I think race oftentimes gets very much overlooked, because I think that the people who are wanting to have these conversations, the people in power, a lot of white people, right, they tend to completely just overlook race and the fact that, wait, we need to hear from Black and brown trans folks, right? But yeah, I went off on a bit of a tangent, but I wanted to add that. I felt like that was very, very important to add and needed to be talked about.
Well, but Ariel, I think that's good, because one of the questions that we need to talk about is things like insurance and unemployment.
Mm-hmm.
And I would assume that those sorts of things impact transgender persons of color, like you've alluded to, even more so. Like probably the employment rate for a trans person of color, the unemployment rate is probably higher than for the cisgender white population. Would you say that's so?
I definitely agree. And I would say that not to get into women gender studies, but I would say the closer you are to whiteness, the less challenging it becomes to find access to care, because everything is centered around whiteness, right? And so if you're dark skinned, Black, trans femme, right, you are, in my case, right, you are going to find pushback at every corner of your identity, right? And so I think that I would agree. You know, it's a lot easier for a white cis straight man to find care than it is for a dark skinned Black trans woman, because when you're a white cis man, you aren't thinking about, okay, is this doctor going to discriminate against me because of my gender identity? Is this doctor going to be racist? Is this doctor going to just write off the fact that I'm in pain because I'm Black, right? You know, is this doctor going to be fat phobic, right? And I think that's something that white doctors and white medical practitioners need to be aware of, is that there is a world that exists outside of white people. There is a world that exists outside of white culture, right? Because I think what happens is a lot of medical practitioners will just disregard people of color's lived experience and will just assume that everyone lives the same way, when that is not the case at all.
So Ariel, one of the questions from the audience is, what is the experience of the trans individual's experience when going to the emergency department? And I'm sure it's different for every person, but what have you experienced, or what have your friends experienced, or what horror stories or good stories have you heard about having to go to the emergency department? Because the emergency department, you often don't have a chance to prepare yourself for that visit, and you know, like you're in crisis and there you are.
Right.
And like people, they're are never their best selves. And those of us who work in the ER and those of us who are patients in the ER, sometimes the stress of all of that is difficult for everybody. Could you talk a little bit about that?
Yeah, I personally have not been to the ER, right? So I can't personally speak to that experience, but from the stories that I've heard from my trans friends, there have been moments where they've worried that whoever the medical practitioner is going to write off whatever health issue they have as, oh, well, that's just because of hormones, or are you sure it's not because of hormones? And there's a term for this, and someone feel free to chime in if I get it wrong. It's just called like the broken leg syndrome, I believe. But yeah, Jonah said it right. Trans broken arm syndrome, where they relate every single medical issue you have to your transness. And so that's been the biggest story that I've heard from trans people who have gone to the ER.
And I can speak to that too. Like I thankfully I haven't had a terrible experience in the ER. I have been there once, but on the topic of the whole trans broken arm syndrome, like I remember going to an urgent care for a strep test. You know, like I was sick, I thought I had strep throat, nothing to do with my transness. And the nurse practitioner who was working with me spent the entire time asking me if I had had the surgery and telling me that I looked good. The implication being, you know, that she doesn't expect trans people to like look good, whatever that means. And it was very dehumanizing, and I felt all this pressure, you know, to talk to her about my medical history that had nothing to do with the reason I was there. And so, yeah, you best believe that dissuaded me from going to another urgent care. And the same is true for the ER. The one time I went to the ER was at UC, and it was, luckily for me, it was a fine experience. I think I have the benefit of, I had had a legal name change at that point. I looked like I do now at that point. I sounded like I do now, like I had been on testosterone. So I pass, quote unquote. But if my name didn't match, my ID or whatever, I think it would have been a lot more of a difficult experience. And I will say too that UC, other than for adults, UC is the only non-faith-based ER like in this area. And so I know most trans people, myself included, are too nervous to go to Christ or Good Sam or anything if they need an ER, because the faith-based portion of it makes them scared about how they'll be treated. I can't speak to like any specific stories about how people have been treated at any of those hospitals, but there is a reputation among like faith-based communities for not being very trans friendly. And so that extends to the ER too. So even if you live right next door to Christ Hospital, that might not feel like a safe place for you to go as a trans person. So there's an access piece there. And then also from what I've heard from patients is that folks who have had bad experiences in the ER, like being called the wrong name, being, victim to the trans broken arm syndrome, having their, whatever they were there for, being written off as somehow a result of their transness, that can sometimes be more traumatizing than whatever led them to the ER in the first place. And I feel like, as a social worker, when people are in like acute mental health crises, I'm supposed to tell them to go to the ER. And I do, but like I say that with a lot of hesitancy because often I feel like the ER is a worse place for them to be if they're having a mental health crisis. And I have patients who have legitimate trauma from being in the ER or from like stays in the hospital. So we work to find, mental health plans and safety plans that work around that. So it's really difficult is the short answer.
And even though I'm the moderator, I will tell you about a situation that I had. I had a young child, probably about 4 or 5, assigned male at birth. They went to an outside ER in the tri-state region because the child was having testicular. They came into the ER in a little dress, parents were calling her whatever her chosen female name was. And they get back to the exam room and they're so busy thinking the parents are abusing this child that they're sitting there trying to call children's services to take the family in because they're allowing their child to wear a dress. In the meantime, the testicular torsion is getting worse. I managed to get the child out of that situation into RER, and our urologist took them to surgery, but they did lose the testicle. So it does have, people are like, oh, it couldn't happen around here. But, people who are cisgender, healthcare providers who think we're doing our best work, but it still does happen around here for whatever unfortunate reason. So the next piece, we have a lot of good questions coming in. So the next piece that I just want to ask about is, what are some specific health issues that trans people face? And Sarah, I'll let you talk a little bit about that. One of the questions is, about sexually transmitted infections and about HIV. And I know there's a question in the question that we'll talk about later. But, are those, do we see more sexually transmitted infections, including HIV in this population would be one of the questions. But then I'm sure there are other questions, there are other medical things we should think about as well.
Yeah, well, first I'd like to kind of follow up and thank Ariel for her really important perspective. And I think all of us as healthcare clinicians must reconcile our own contributions to the systemic racism and systems of power that have kept minoritized and marginalized patients oppressed. I put a link in the as to one of the responses in the Q&A. The 2015 national trans equality study looked at over 120,000 trans-identified folks living in the US and their experience of poverty and homelessness and police violence. And in all of those categories of life disparities that affect health and life disparities that affect wellness, people of color, especially women of color, femmes of color, had higher disparities. And there are some breakout statistics for Latinx, Black, Indigenous persons kind of within that report, and I placed one. So, if folks are visual learners and they want to see some raw data of what experiences look like on paper, it's a really helpful document to show us where our growth must be. Agree with everything that was said too about the ER experiences. And there were two pretty well done studies in 2017 and 2018 that really support the things that we're talking about avoidance of care because of concern of the ER. One of the things I certainly talk about, especially with my patients of color, if there is an emergency, the default is really not calling 911. For many of my patients, the idea of interacting with the police when they are in a mental health crisis or even a physical health crisis, that is not an option. So, we really want to navigate what is a safety plan. If it's not 911, and I agree, in many cases, that is not the thing that's going to promote safety. But so we have to be thinking about that when we're thinking about health outcomes. And that frames, what are we looking at when it comes to sexually transmitted infections or HIV? Trans women, especially trans women of color, are 4 times more likely to be living with HIV than cis folks and even trans folks who are white. And some of that is all the things that we have talked about, the stigma, the intersectional stigma of being a person who lives with HIV. If somebody is working, within industries where their risk of STI transmission might be higher, there's stigma around that. There's stigma around identifying as a trans woman in general, then add on an identity of color. So all of those things do equate to differences in outcomes. And it's one of the reasons why thinking about PrEP and pre-exposure prophylaxis really for anybody who is having sex, anybody, what is, the risk is anybody who's having sex, but certainly in persons who haven't had great access to healthcare, who deserve to have other tools to keep themselves safe and to keep themselves safe in both sexual relationships, but also who might be victims of violence. So trans women, especially trans women of color, are more likely to be victims of both physical and sexual violence. So thinking about STI prevention, from sex that people might be having consensually with partners, but also sexual acts of violence that people encounter throughout their lifetime. So we want to also just think about, that even STI screening is not a one size fits all approach. What I see a lot of times happen is, people collect a urine sample and they think, well, if that's negative, then the person doesn't have anything. And okay, well, let's really reframe that. We really want to think about exactly what Ariel said. How are you loving on folks? How are they loving on you? Where should we think about swabbing? Let's talk about doing self-swabs, right? Let's give that trauma-informed approach to STI screening and to the physical exam so that we can empower folks to want to come in and say, hey, this is what's going on, and I would really like to have screening or have treatments. And those are just some of the things that we are thinking about, and our approach to these conversations really matters.
And then I think we talked a little bit about, like, for my population, especially adolescents, eating disorders. We take care of a lot of patients who are on the autism spectrum, and thinking about ways, that we can make our office more welcoming and more safe and more, like not harsh lighting and not loud noise and that sort of thing. Are there other things that you think about, like for especially like older adults? Like cancer screening, like are they more likely to not do their cancer screenings and that sort of thing?
Yeah, so folks who have a cervix oftentimes will avoid screening for various reasons: disconnection to that part of their body, previous trauma, changes that happen to the skin because of testosterone use that makes those exams more uncomfortable. So we do see a higher rate of cervical cancer in any folks who haven't had the opportunity to have cancer screening, again, for various reasons. And so we do see that. We also know that because there's higher rates of substance use and smoking, again, oftentimes as part of, systems of stress and oppression and lack of access to other options to manage stress and to manage anxiety and mental health experiences, because of those substances, we can oftentimes see higher risk factors for various cancers, including cervical cancer, lung cancer. Gender affirming hormones themselves, this is a question we often get. Does it put people at higher risk of cancer of reproductive organs? And the answer is no, right? The kind of the risk factors that we think about are, do we have a good way to kind of screen for cancers in those areas, and what might be some of the other contributors? For folks who have experiences of racism and sexism and transphobia and homophobia, all of those are additive and they will result in poorer health outcomes. And so we do see, higher rates of diabetes and hypertension and coronary artery disease, because without the social support and access to care, acceptance, community, all of these things that really help people achieve health, especially in the US, that we will see differences in outcomes in those areas. And keeping people in care, the little things like chosen name and having the electronic health record reflect authentic identity, those are life-saving, because they increase the chance that somebody will stay, that they will allow us to try to right some of the wrongs, the historical wrongs, and the experiences that even these individuals have had previously with healthcare settings.
Let's talk a little bit about fertility for a minute. Because a lot of insurance doesn't cover fertility preservation, fertility treatment. Oftentimes you're asked to stop treatment in order to do fertility preservation. What have been your experiences around that topic?
Yeah, so oftentimes these are conversations that we try to have, early on in thinking about hormone therapy and just thinking about just general health and life plans. But I will tell you, nobody has to know the answer to whether they want to parent or how they might want to parent or if they might want to parent. So one of the things is that it's okay not to know, and it's okay for that to change over time. But sometimes early on, we think about sperm cryopreservation or egg preservation as options to explore and talk about with patients. In the studies of folks who could produce sperm and who have been on hormone therapy, the best samples, the samples with the highest rate of being able to have the highest sperm motility and the best options for preservation, were folks who had not been on hormone therapy in the past. However, if folks stopped their hormone therapy for between 3 to 4 months, the sperm was about equal to those who had never been on hormone therapy. Now, that is a loaded ask for a lot of patients, to put a pause on medical interventions that are life-saving and life-changing. So with that said, I have lots of folks who might decide to do some cryopreservation and family planning before they start hormone therapy. Financially, it's a little bit more cost-effective over the last few years. So for example, in Cincinnati, somebody can give an initial sample and the analysis, so making sure that the sample is one that they would feel comfortable freezing and keeping in storage until they decided to use it or not. It's about $200 and then about $100 a year. If we look at folks who might want to use assigned organs and do egg preservation or even ovarian tissue preservation, which is still it's an up and coming technology that's been used in a lot of onco-fertility, so a lot of cancer-related fertility preservation. Those things are really expensive, and those are between $5,000 and $12,000. They are rarely, if ever, covered by insurance, really for any indication. For folks who want to do an egg freezing or ovarian tissue preservation, those are things that can be done even after hormone therapy has initiated. Typically, people would stop hormone therapy for a certain amount of time, typically, again, between 3 and 4 months is what most of our fertility docs will recommend. And they'll do the cycles to preserve the tissue, and then they would restart their hormone therapy. For folks who want to stop hormone therapy and then become pregnant and be the caring parent for that pregnancy, success rates are anywhere from between 60 to 80% after stopping testosterone. Typically kind of return to bleeding cycles and return to ovulation can happen within those first few months. A lot of fertility ability to get pregnant or to participate in a pregnancy has a lot of different variables. So one of the things might be other health conditions that could affect ability to get pregnant, just amount of time on hormone therapy, just with age. So ability to get pregnant looks different at 19 than it does at 29, than it does at 39, than it does at 49 for any person. So those are things to think about. We have typically really kind of checking in conversations now and then. Some people have their family plan kind of really set and they feel really affirmed in that, and it's not something that we have to check in often. But for folks who maybe want to access services or think about assisted reproductive technologies, those are things that we will certainly connect people with. And here in Cincinnati, we've got some great docs that have a really trans-inclusive approach to working with families to help create great families. And there's a lot of ways to parent in this world. And that is something that I hear from a lot of my my patients. And I really, really appreciate that approach too.
Kaeden or Ariel, do you have any comments on that?
Yeah, one of my thoughts was that kind of like on the other end of the spectrum, like one thing that intersects with fertility and trans folks is that trans folks are often left out of sex education, either in school or from their providers. And so a lot of trans people may not even know how to protect themselves from unwanted pregnancy or from STIs. There is, and depending on how experienced with the community their providers are, if they have medical providers at all, they may or may not tell them these things. Like, for example, testosterone, it does stop bleeding, but it's not birth control. You can still very much get pregnant if you're taking testosterone. It's a little bit harder for most folks, but it's still very much possible. But a lot of people aren't told that, and then they end up with an unexpected pregnancy, which you can imagine might be pretty traumatic for anybody, but especially for a person who is transgender. And then what can be more traumatic still is the conversation about options, what does it look like, if I want to carry this pregnancy to term? What does it look like if I want to have an abortion, or or give birth and then place a child for adoption as a trans person. That's really difficult and often not a conversation that is had enough. So yeah, that's kind of another piece that is important.
On the topic of fertility, STDs, and things of that nature, I think what needs to be talked about is the autonomy that trans people have over their bodies, especially when it comes to sex, in the sense that I feel like we don't talk enough about how trans people are allowed to use their bodies in however way that looks, right? So, so whether he wants to use their part, she wants to use their part, they want to use their part, right? However that looks, I think we need to acknowledge that trans people have sex, because I think trans people are seen through this lens of infantizing. But not only that, I feel like trans people are also seen through this lens of asexuality, in the sense that people don't think that trans people just don't have sex, right? Trans people have sex. They have sex with each other. It is a thing. And so with that, I think that there needs to be a little bit more conversation around the options of fertility and what does fertility look like. Because I remember starting out on hormones and kind of thinking to myself, what does it look like to even have a child as a trans person, right? No one really talks to you. No one really talks to you about these things. And I feel like for a lot of millennials and Gen Zers, the way we go about things is we don't acknowledge it, it doesn't happen. Right? We don't acknowledge it, it doesn't happen, it doesn't exist. Right? And I would like for there to be more conversation around this. I would like for the topic of trans people and sex to be normalized. But I think that's really my thoughts on the topic of trans people and disabilities.
So for the last 20 minutes or so, we're gonna take audience questions. So I'm gonna read a couple that are on the screen now. So what is a trans-friendly recovery fellowship, in person or online? We have a clinician here who's in the addiction field. Is there a fellowship that includes recovery? I know I've seen a few, like you did, Sarah, new fellowships popping up for transgender care. Are there any related specifically to addiction?
A lot of substance use fellowships that have kind of that biopsychosocial model for docs, either through psychiatry or family medicine, really do have a gender inclusive lens. Do they have specific learning objectives? Those fellowships are not ACGME accredited. So what that means is there's not a specific algorithm that they all have to follow. So each fellowship would probably have its own spin on their approach to trans inclusivity and to gender spectrum care. Certainly when we think about any mental health training program, the idea that it would be gender inclusive and that folks would feel really comfortable and confident finishing that fellowship, which suggests that this is additional training beyond the already kind of fundamental training somebody has. Certainly, we would always hope that that would be included. Within family medicine, we have very specific kind of training models that look at gender, including transgender medicine fellowships. Hopefully, there will soon be an ACGME transgender medicine fellowship that residencies in medical schools around the country can choose to be a part of. I think when the study that Dr. Stryker, who's one of our other docs in the Department of Family Medicine and also a physician at Equitas Health, the study that we published that looked at clinicians in multiple fields, so social work and pharmacy and surgeons and medical docs doing hormone therapy and sex therapists, how did they get training? They got it on their own. They went to conferences, they networked, they mentored, they were mentors. So I still think that that is a really, really important and probably the most important training opportunity that practicing clinicians, so those who are out of residency, who maybe won't have an opportunity to do a fellowship, even an online fellowship that you could do while you're, still working full time, is to seek mentorship and to do the WPATH GEI conferences and to do the, Fenway Health conferences and the Harvard conference in October and get the additional education to be able to prepare ourselves to care for what will hopefully be a growing, beautiful population of trans folks who are ready for great clinicians to meet them where they're at.
And I have a question about training for all of you. So in order to get training, one of the things that we have to do is have trainees with us in clinic. And sometimes that can be hard, because sometimes patients are coming in and they want to talk to us privately, but then you've got this medical student or this resident. So it feels like it's kind of a trade-off sometimes, like I want to make sure there are people around when I'm dead and gone who can do this care. But in order to do that, I have to train them seeing patients. Kaeden and Ariel, how do you feel about that? And Sarah, pipe in too. Like it feels like a balancing act sometimes.
So I cannot speak to other trans people, so I'll just speak for myself. When it comes to like, so you're referring to medical students who like sit in?
Yes, medical students
Okay.
or residents or fellows, any of
Okay.
ours. We have a social work student right now. I mean, the best way for a social work student to learn to do trans care is to actually do the care. Like reading about it in a book
Okay.
isn't the same. But then sometimes it's like I'm sending them in and they may use, we're trying to train them to use the right pronouns, like how do we balance that so that
Right.
we're making sure we have enough providers, but yet we're still providing good and competent and personalized care.
So I know for myself, I am a firm believer in like education, and people learning how to be more not just open-minded, right? But like educating themselves like trans issues and things like that, right? So when it comes to med students, sitting in, as long as I'm asked beforehand and I'm being told, hey, we have a medical student, is it okay if they sit in, right? As long as I'm told beforehand and it's not just, hey, Ariel, by the way, this random white person's going to sit in, here you go. And so for me, I think a big thing is consent. Are you okay with this? Are you not? Because what it comes down to is, not all trans people are the same. And just because I'm okay with this doesn't mean the next person is okay with this, right? And if there's anything that I know, it's that, like I said, I am a firm believer in, in education, and I'm also a firm believer in the saying, when you know better, you do better. So.
And I could add that, like, I agree with Ariel in that, especially having been sort of now on the provider side, like, I recognize and strongly value the importance of teaching and giving folks, med students and the like, opportunity to learn about this care. I agree that that's super important. On the patient side, sometimes I feel like you can feel like kind of a guinea pig. I feel like both in the medical setting and just kind of like in your life, I feel like it's really easy for people to look at trans people as like, as this like interesting case, like, ooh, we can all learn from you. Like, ooh, like, you're, you're special and you can teach us all these things. And that's a lot of pressure when you just want to go to your clinic and get your medical care and leave. It's like, I feel like sometimes the weight, there's pressure to kind of teach everybody and to kind of like help everyone be more trans affirming, and I don't love it. So I prefer, I think for med students and stuff, like I think it's really important for them. There's a certain amount of knowledge that I agree that they can't get without actually working with patients. But I think it's important for them to do their homework first and ask their questions first, so that when they do walk in to see me as a patient, they're not tripping over themselves about what body parts I have or what have you, and putting the pressure on me to correct them and teach them. I've had both experiences. I've had med students who were great and fine, and I've had ones that made me feel really uncomfortable, and I felt like I got less good care because I was sort of, teaching this person on that particular day.
So then I think the last two questions kind of go together, and then there's one about autism that I can answer. But one of the questions is, what are some ways someone who does testing in an outreach setting can go about asking who folks have sex with, what that doesn't ignore, assume, deny gender orientation? It ultimately seems that you just need to know which body parts are used during sex. How is there a way to discuss that? And the corollary to that is, I would also like to know how to be affirming during outreach when obtaining the sexual history. So if you all could kind of talk about that a little bit, that would be helpful.
Yeah, I can start. I love this question because I used to do HIV testing in an outreach setting. But my kind of approach is like, first, not to assume if you already have like information about their sexual orientation, don't assume that label, if they identify as gay or whatever, don't assume that tells you anything about their sexual risk. Because they might, if I'm a trans man who identifies as gay, you might think, oh, like MSM, oh, they're at increased risk for HIV or whatever. But if I'm having sex with another trans man, my risk for HIV is quite low, and that'll change the conversation. And that'll also change the conversation about condoms and, protection and all that good stuff. So what I like to do is just be very upfront and like as comfortable and casual you can be is better. But I just ask people like, what kind of sex do you have? What body parts do you use for sex? And if they don't know what I mean, like I'll be like, do you generally have oral, anal, vaginal sex? Like, are you using toys or is there a penis involved? Are you using condoms or other barriers? And like, do you have any partners who produce sperm? Like questions like that. I think that puts the focus on the action that can expose someone to sexual risk, and not like without making any assumptions about what their body looks like and what their partner's bodies look like.
Yeah, I completely agree with that approach. That's what we try to model and teach our students too. We want to know about partners. We want to know about practices. Really, I always say, my job is to try to figure out how I can help you either screen or prevent. So what should I know about your sexual health? And really Also, again, kind of thinking about that trauma-informed approach, which we know that trans folks have a high rate of trauma-aligned experiences in their past. And so really making sure that we're using terminology that reflects the language that they use. So sometimes opening with, I'm going to ask you some questions about your sexual history. Do you have any certain words or language that you use to describe the parts of your bodies you have sex with? And that way I can model that language instead of using, anatomic or clinician based language that might be off-putting to a patient. But I love my who's loving on you and are you loving on anyone, and then we can kind of get into the details. The AAMC, the AAMC has some awesome videos that model sexual history taking across the gender spectrum, the spectrum of sexuality, and it's a really great video series that you can Google AAMC sexual history taking to kind of practice modeling some of this stuff and practice before we see folks, right? And I agree with students, kind of learners being part of it. Everybody gets to decide in that moment whether they want to talk with somebody else other than me. And just because they wanted to at visit A doesn't mean they're going to feel like they do at visit B. And we never will put student or resident learning in front of patient safety and their choice to be involved. And there are some days where people would love to have extra people to talk to. And for folks who might be a little bit more isolated when they come to the doctor, might be a time that they've got a lot of stuff to share. And a learner can be an awesome listening ear too. So I think we can find that balance.
And I would like to add too with the sexual history question. I think that transparency and consent is also really important to consider there. And by that, I mean, like, get people's consent to ask them these questions and explain why you're asking them. I'll often, before I get to the, like, what kind of sex do you have, what body parts are you using kind of thing, I'll say, like, so some of these questions are about sexual health. Is it okay to kind of get into it? And then I'll say, like, I know this seems invasive, but the reason I ask is because we want to know what kind of sexual risk you're exposed to, et cetera. And so I think that knowing the reason why you're asking questions, and that it's not like a morbid curiosity about what's in your pants, and that it's really about kind of, what sexual risks that you and the patient need to be aware of, I think that makes people feel a lot more at ease.
And can you address differences and barriers that trans masculine versus trans feminine versus non-binary persons experience? I think, and for me, taking care of non-binary persons, people are always like, oh, but if they're non-binary, they don't need hormones because they're not, like, people are very into, we were talking about this in clinic the other day, with one of the parents that Kaeden and I saw, how, people used to be like, oh, well, you either have to transition to masculine or you have to transition to feminine, there's no in between. So, and that's why I hate to call them cross-sex hormones, because that assumes that there's only two sexes. But go ahead, Kaeden.
I'll just say that, starting with, to that point, starting with folks who are non-binary, I think in some ways could experience the most barriers. Well, there's certain barriers that they experience because I think there's an assumption among lots of people that transition can look two ways. It's either from male to female or female to male. And so there's an assumption that non-binary folks either don't want medical transition, or that if they do want medical transition, that they're not actually non-binary. And so I feel like there's often not really sensitivity to where to even begin, and how to even talk to non-binary folks. But then, and I think Dr. Pickle and Ariel can speak to sort of the difference between barriers to care for trans masc and trans feminine folks. But yeah, I'll often say I think, well, here, I'll let them speak to that. And then I might have.
Yeah, I think barriers to care for I think barriers to care for trans femme folks. I think I would say that probably includes stigma centered around trans feminine folks, and you know, like and that stigma being, you know, that everyone wants to write trans women off as being creepy and this, that, and the third. But I think another barrier too is the way that because society is already pushing down on cis women historically, right? They're going to push down even harder on to trans women, and then trans women of color, and so forth. And so I think a barrier for trans women receiving care is just trans misogyny, and how rooted trans misogyny in our culture is, and how much transphobia in itself is rooted in trans misogyny.
So we have about 2 minutes left. If anybody has any closing, anything in closing they'd want to say, I think this has been a really great dialogue. Thank you all for participating in helping.
Kind of back to the point of you know, trans masks versus trans femme folks' experience in healthcare and stuff. I think it's interesting how like the cultural landscape around like trans folks is shifting a bit, because historically I think that for trans women it was a double-edged sword. You know, they were simultaneously more visible, like both in the media and just like for most people, when they thought of a trans person, they thought of a trans woman. And so there was a little bit more awareness, and there was potentially like more positive representations in the media. But by the same token, they're more often like victims of like homophobic and trans misogynist violence. They're perceived as being creepy and sexual predators, which naturally, you know, puts up a lot of barriers to care. And then trans men historically have sort of flown under the radar, but now more recently there's been this big conversation around trans men as being just these like poor mentally ill girls that have been like seduced into becoming trans, and so that brings with it its own like host of challenges and stigma aimed at trans men. And so yeah, I think that we're both trans masculine and trans feminine folks are both like victims of stigma and barriers, but just in different ways.
So thank you, everyone. Our time is up. Don't forget to use the link to give feedback on the SurveyMonkey. And if you're doing continuing education credit, don't forget to fill out the evaluation by 5 o'clock. Thank you.
All right, thank you all. Dr. Conard covered it right there. So we hope that you'll join us again tomorrow. Our friends at Planned Parenthood will be doing a deep dive into intersectionality. So thank you all for attending, and thank you for a wonderful discussion today for our panelists.